punctual. I welcome you for our webinar on long gap esophageal atresia about quality of life. And I'm really honored here to be the moderator of this wonderful team. I may introduce Michaela Delmark-Blom from Sweden. She is a quality of life researcher representing the Queen Sylvia Children's Hospital in Gothenburg, Sweden. And there is Jens Dingemann, head of pediatric surgery at the University Hospital of Hanover. Myself, I'm president of EAT, the Federation of Esophageal Atresia support group. We are acting globally, and I'm EPEC in ERNICA. And why I'm here today is that I'm a mother of a now 25-year-old young man who was born with a long gap esophageal atresia. I will share my screen and will show you just in a few slides how our patient journey was. Maybe I mentioned that this webinar will be recorded for all colleagues who couldn't make it today. So we will talk about health-related quality of life in long gap esophageal atresia, current knowledge. So what do we know? Knowledge gaps, what we don't know, and what we should know, and where is the implication for future research. I did this. The 3 people presenting. So just a quick look back. If you take it, I'm overlooking 25 years of the ongoing patient journey, not only of my son, but of many other families with children born with a long gap esophageal atresia. Probably some of you know this, what we did as patient support groups from many countries. We tried to develop the patient journey, which shows from the prenatal diagnosis if happened, over the diagnosing, the surgery, the postoperative care, the initial discharge, start eating, kindergarten or school, follow-up, transition, leaving home until retirement. And I will talk just shortly about the burden of this start, which strange journey of the whole family, not only of the patient. And maybe if I would conclude, for the patient, it's even less than for the rest of the family. So my son, and you don't have to read everything, I want to show you what it means to have a child with a long gap esophageal atresia. It hits you. You get this diagnosis and you are hit already by the name. You first have to learn to pronounce it. And the first 5 years of life, they are very dense in challenges, complication, fallbacks, and so on. If you look on the purple bubbles, those are the bubbles where you, as a multidisciplinary expert team, are very important for the result, the medical result, and from this, for the quality of life of this child. So the collaboration between all people and later between the hospital and the local treatment teams, the structured follow-up, especially the pulmonological issue, and initially the sham feeding were the core topics I'm convinced were important for the life quality of my son. Besides this, we had a strong patient organization at our site. CAKES exists since 40 years, so we had feeding recommendations from CAKES. We had the exchange with other parents, and we were very well informed about what we have to look after, especially, again, the lung issue. And we had a huge social environment who supported us. We had understanding teachers later. Our family system worked. The siblings were very important for my son because they were sitting there, were eating, so he wanted to do this as well. And we had a stable financial situation. Still, it was not easy. We had 21 days ventilated because of a severe tracheomalacia. Still, he was discharged after 4.5 months. But then we had this every 4 weeks a viral infection, bacterial and bronchitis. And so with 1.5 years, he had a breathing ileus. So we were exhausted as a family. But it got better. Again, it was important for us, you see the magenta, that we had a collaboration between the pediatric surgeons and the gastroenterologists in the treating hospital. And we had support by a retired pulmonologist who was very eager to treat our son, conserving the lung. We had, again, cakes on our side. Even in COVID, when he was already adult, it was cakes who organized the early vaccination. And we had all those other things like having football and physical activities. And today he's compensating some minor issues like a severe dyscalculia with artificial intelligence. So what he's doing today, he's studying sport and history, and he will become a teacher. So my message is we need a lot of support initially. We have to see the child around the esophagus, not only the esophagus. We have to encourage and enhance the whole family, because often the quality of life of the parents and the siblings is much poorer than the quality of life of the patient. And we have to save the lungs of those patients, because I think this is an issue which is underestimated today. So I go out of my presentation. This was a very quick overview over 25 years living with a long gap esophageal atresia patient. And I want to invite Jens for the very basic things. What is an esophageal atresia from the surgical point? Jens, please share your
I will. Thank you. Thank you, Anke, for the kind introduction. Thank you, René, for giving us the opportunity to do these webinars with ERNICA. I think it's really great to widen your knowledge through the technical possibilities here, hopefully for our participants. So as we didn't know about the audience we have today, we decided to start from scratch. I have to share my screen, sorry for that. And we decided to start with Anke because when you listen to Anke, you get an idea of why she's so motivated with this topic. It's her journey. It's the journey of her family. And I only talk to you as the surgeon about, can you see my screen? About the surgical things on long gap. So we decided to start from scratch. What is esophageal atresia? It's characterized as, as discontinuity of the esophagus. Is characterized by the presence or absence of the tracheoesophageal fistula. And this is most important for today's talk, the distance of between both esophageal ends. This is what today's focus is. A quick glimpse on the classification of EA. So we're mostly but not only talking about type A, but also about types B, and D and also C can be long gaps. So this is the first thing you need to understand, that not only type A will be a long gap. And this is what it looks like. So on the left side of the screen, there's a typical type A esophageal atresia, or the first X-ray on the first day of life, where you have a gasless abdomen and a replogal tube in the upper pouch. So this most probably will be a long gap. And then on the right-hand side of the screen, you see how we, or one of the ways to measure the gap between the upper and the lower pouch. And then things become fuzzy, I have to tell you, because what is actually long gap EA? It's really not very well defined. If you look into the literature, the gap between the both esophageal ends is more than 3 to more than 6 centimeters. It doesn't sound a lot, but for a surgeon, this is really a big difference, or between 2 and more than 5 vertebral bodies in the X-ray. And some authors in the literature always define it as a functional long gap EA, where an anastomosis is not possible or has failed for any reason. So to bridge that gap, there are different surgical principles, which I will tell you in detail later on. On the one hand side, you may preserve the native esophagus with delayed anastomosis of both ends, plus minus bouginage, plus minus traction or elongation techniques. And on the other hand, there are the replacing techniques, which are known as gastric pull-up, gastric tube, colonic interposition, and jejunal interposition mainly. So about the definition of long gap esophageal atresia, there is no, or there has been no consensus until the ERNICA consensus conference, which took place in 2020 and published in 21. So consensus was reached for the definition. Long gap EA is, sorry, my presentation doesn't work. Any EA without air in the abdomen should be assumed at least to be a long gap, and also that any EA with more than 3 vertebral bodies on the X-ray should be considered a long gap. So this was the only consensus that could be reached on that conference in Berlin. So what are the methods in detail? I talked about a few before. So the first is preserving the native esophagus with an anastomosis. It could be delayed. So delayed anastomosis means usually after 3 months, you do the final operation, the reconstruction of the native esophagus. So today, I suppose no one is still doing like Rehbein's bouginage of the esophageal ends. So waiting and delaying the anastomosis is one option, preserving the native esophagus. And then there are the different traction and elongation procedures known as external traction, or the Fokker method, where you try to elongate the esophageal ends to bring them together at a later stage. So this is all extracorporeal traction here on the back of the patient. And then since a few years, Patkowski has introduced the internal traction, usually in the thoracoscopic approach, where you connect the ends of the esophagus and increase the traction in a couple of days to reach later anastomosis. Another elongation technique is Kimura, and you can see on the right lower side of the screen that you start with a spit fistula on the neck. So the upper pouch is brought out on the neck and is then moved down to elongate it. So here 4 steps on this picture of the Kimura technique, which elongates at least the upper pouch. Okay. Another method would be levadetis, myotomy. Here you can see the incisions in the esophageal muscle, which allows the esophagus to stretch. This I will come back to that later. And the replacement methods, so the ones that are usually shown in the literature, certainly gastric pull-up. You heard that from Anke and her child. So the stomach is brought up into the thorax, just behind the heart, is then sutured together with the upper pouch, which you can see here on the right-hand side of the image. So another replacement method is the colonic interposition, where you connect the upper pouch to the stomach with the colon, either behind the heart or retrosternally, and different parts of the colon will be taken for that. So that's the second replacement method. And another one is the jejunal interposition, where you connect the stomach and the upper pouch with a piece of small bowel. Okay, which way do we go? How does the surgeon know which method will be right for the particular patient who is brought to us? So APSA, the American Pediatric Surgical Association, has published a guideline which I think doesn't really help for the individual patient. So you can see what literature they screened. You see there are not many studies out there regarding the definition, a few more for the surgical options. Many for the outcomes of the patients. So this is not a lot because the time where they collected the papers was really long. So at the end, there is an algorithm which I think doesn't help for the individual patient, because you can do almost everything. Yeah, so saving the native esophagus seems to be an aim of this guideline. You can do lengthening, you can do gastric transposition, you can do replacement. So when you give that to a young pediatric surgeon and ask him what to do, he or she will not really know according to that guideline. So the reason for this is there is not much evidence out there, and the patients are individual. So again, during the consensus conference, the question was asked what about the reconstruction techniques, and the experts who met there in Berlin said, okay, preserving the native esophagus should be preferred with delayed anastomosis or axial lengthening as an option. Jejunal interposition is also an option. Gastric transposition is also an option. And no consensus was reached on Kimura shouldn't be done, and other lengthening techniques as levadetis shouldn't be done, and no consensus could be reached for the colonic interposition. Okay, still we know a bit more from the experts now, but this is not the high-grade evidence you wish for as an academic surgeon. And I asked myself the question, is there more evidence out there? So a little reality check just on recent publications on that topic. And in the first place, I will give you the key messages of the different articles. There are only 3 or 4 there. So this was a study between 2 centers, Gosh in London and Wroclaw with Dariusz Patkowski. So 2 centers, 52 patients with long gap, similarly divided between the centers. But the first thing is different definitions of long gap esophageal atresia, multiple surgical approaches and surgeons, so very differently treated in the one hospital and one method in the other hospital. So my conclusion, if I reviewed this paper, would be there are just too many confounders in that study to draw reliable conclusion what is actually better. Okay, next study, also published in 2024. A single center study, at least, could be good. 70 patients with esophageal replacement. But when you look into the replacement methods, you find 1, 2, 3, 4 different methods. So this is not a homogeneous collective. And what they did actually, they compared the laparoscopic approach for whichever against the open approach. And they said, okay, there are similar results in these 1, 2, 3, 4 different techniques if you go open or laparoscopic. So my conclusion on that paper is still limited numbers. 71 is not bad, but it's still limited to draw conclusions. And there are 4 different approaches, and also the follow-up in that study is limited. Okay. A bit more you can learn from it, but still the main and the key question cannot be answered. So next article from Michael Böttcher, single center, just 26 patients with long gap. They had 13 delayed primary anastomosis and 13 gastric tubes here when he was still in Hamburg. Results seem to be similar, complications seem to be similar, but what does it say? I think still the numbers here are very low and the collective is really heterogeneous because every patient has his or her individual problems. Then Gallo et al., this is a bit older, but I think they tried to get the best information you can get from the literature. This was a meta-analysis, so comparing different studies, and they collected 264 long gap esophageal atresias, again with very different surgical approaches. But the problem of that meta-analysis is the outcome parameters were not standardized. The collective is heterogeneous, and there were only 2 directly comparative studies. So my conclusion here is a reliable meta-analysis is just impossible when you don't define the outcome parameters. So taken together, the problems after correction of long gap esophageal atresias, there is no clear definition of the malformation, or in better words, how long is long gap. There are many different surgical approaches out there, and there is no clear definition of outcome parameters. So what is actually a good outcome in long gap EA? And most data are surgeon-defined outcomes. So we, as a surgeon, define our own outcomes. This comes with different problems as well. So my opinion and conclusion is what we actually need is a robust, reliable, and well-defined outcome parameter. And this is my personal vision as a surgeon. I think patient-reported outcome measures add important information also in long gap EA. And my vision, or better said, my dream or my hope is that we find the optimal surgical approach for long gap, because we still don't know. And what we need to do is an ambispective investigation, meaning we have to look back to what we have, and we have to look prospectively on the patients we operate, how the outcomes are. And there is, since more than 10 years now, a disease-specific instrument out there to measure health-related quality of life with EA-COL. And I think we need to apply this to a large cohort of long gap esophageal atresia patients, and have to divide them up between the surgical approaches using this specific instrument for esophageal atresia. And here comes Michaela, because this is her main interest and also her main expertise. And I'm very happy to work with Michaela, also with Anke, for so many years now. So I stop sharing my screen and look forward to the discussion later on.
Thank you, Jens, for an excellent presentation. Thank you, Anke, for always providing your important and touching patient perspective. So my part of the presentation will focus on health-related quality of life. And I wonder if you can all see the screen now. I hope so. Otherwise, tell me. So why do we focus on health-related quality of life? Well, health-related quality of life is today recognized as being an important element of care and treatment in patients with esophageal atresia, and this is stated in our international recommendations. So what do we then mean by health-related quality of life? Well, importantly, this refers to a multidimensional term encompassing the self-perceived impact of disease and treatment on physical, psychological, and social functioning and well-being. It should be the patients who rate their own health-related quality of life. In pediatric populations, however, parents can provide an important complementary source of information on the child's health-related quality of life and is often used. As we are going to review how health-related quality of life has been assessed in patients with long gap esophageal atresia, I wanted to remind you in the audience of the different measurement approaches. I'm sure you recognize this. But as you can see illustrated on this slide, the most broadest measurement approach is to use generic questionnaires. These questionnaires, they ask general questions that are considered important to people independent of their health status. And this way to ask enables comparison of these outcomes between patient groups and healthy or general references. Now, one step towards clinical sensitivity is to use a chronic generic or a symptom-specific measurement approach. These questionnaires are adapted for a broader patient group, such as those with, for example, gastrointestinal symptoms. Now, the most narrow approach to measure health-related quality of life is to use disease-specific questionnaires for esophageal atresia. And they are usually more clinically sensitive to capture disease severity and treatment response. They also ask questions that have been proven to be of importance to the selected patient group, such as in this case, esophageal atresia. And compared to the generic questionnaires, these questionnaires have been evaluated more recently. So how did it all start? So this is very interesting. The first articles on quality of life in patients with esophageal atresia in both children and in adults actually focused on long gap esophageal atresia. And the study by Ore et al. From 1995 included 8 patients with colon interposition for long gap esophageal atresia. And it was actually a historical milestone as this was the start of health-related quality of life research in patients with esophageal atresia overall. Now, almost 30 years have passed since this article was published. It is interesting to ask what has happened since then. If you update the literature search, if you go through the literature, if you include health-related quality of life questionnaires or quality of life questionnaires that are psychometrically robust, they are valid and reliable. If they have been used in studies trying to evaluate different treatments in long gap esophageal atresia. They have not mixed patient populations with esophageal atresia with other patient populations and not mixed ages for children and adults. What do we find? So we have included 6 articles in children with long gap esophageal atresia, and they are listed on this slide. As you can see, the sample sizes in the specific treatment subgroups are often very small. The median sample size is 13 patients. And if you exclude esophageal replacement as a whole, as this can also be a heterogeneous group of patients, the median sample size is 9 patients. All of these studies are cross-sectional and, as you can see, also mostly from Europe. No study is international. This slide shows how health-related quality of life in children with long gap esophageal atresia has been evaluated. And as you can see, it has mostly been evaluated using generic health-related quality of life questionnaires. And as in many cases in pediatric surgery, the PEDSQL generic core scales have mostly been used. One study has applied a disease-specific health-related quality of life questionnaire in children with long gap esophageal atresia. These studies mostly show that there are no significant differences in health-related quality of life between different treatment subgroups in long gap esophageal atresia, such as between delayed primary anastomosis and gastric sleeve pull-up, between delayed primary anastomosis and esophageal replacement, gastric pull-up and jejunal interposition, esophageal replacement and healthy controls, and thoracoscopic external traction technique and healthy controls. One study has identified some differences with favorable health-related quality of life results for delayed anastomosis. This study has recruited patients from a patient support group, and the numbers are quite small. The favorable health-related quality of life results regards physical well-being and autonomy and parents, and is favorable compared to healthy controls and esophageal replacement, respectively. It has been difficult to identify risk factors for poorer health-related quality of life results within the group of long gap esophageal atresia. One study has shown that there is a strong negative correlation between days to hospital discharge after repair of esophageal atresia and a number of associated anomalies with health-related quality of life in children with long gap esophageal atresia aged 2 to 7. And in children with long gap esophageal atresia aged 8 to 18, presence of different digestive or respiratory symptoms are related to worse health-related quality of life. Similar to the pediatric populations, also in adults with long gap esophageal atresia, we could include 6 articles based on our inclusion criteria. As in the pediatric populations, the median sample size in specific treatment subgroups of long gap esophageal atresia was very small, 8 patients. All studies are cross-sectional, mostly from Europe, and no study is international. In contrast to the pediatric populations, the most common way to assess health-related quality of life in adults with long gap esophageal atresia was to use a symptom-specific health-related quality of life questionnaire named GICLI, the Gastrointestinal Quality of Life Index. These studies mainly show that there are no significant differences in overall health-related quality of life between the different treatment subgroups compared to healthy controls or to primary repair. But there are some studies that have shown that there are significant difference between treatment subgroups, with poorer health-related quality of life outcomes in the long gap treatment groups compared to the healthy population. And this regards delayed primary anastomosis and esophageal replacement and colon interposition, respectively. The common thing for these studies are that they have used, as marked with the green color, symptom-specific or a disease-specific questionnaire for esophageal atresia. There are some significant differences found regarding health-related quality of life domains, with worse outcomes for physical functioning and symptoms in adults with esophageal replacement compared to healthy controls, or between colon interposition and primary anastomosis or healthy references. One study has also noted better outcomes regarding social functioning in adults with esophageal replacement compared to healthy controls. Important to mention is that Tantani et al. Conducted a systematic review on the quality of life assessment focusing on long gap esophageal atresia, and it was published in 2019. They included 6 studies with 105 patients described as long gap type A or B esophageal atresia. Follow-up in years were reported in 3 of these studies and varied greatly. All studies were cross-sectional, and these authors concluded that patients with long gap esophageal atresia may suffer from more gastrointestinal symptoms than controls, but there is no significant differences in health-related quality of life. So to conclude, it started in 1995, and over the course of soon 30 years, there are 11 health-related quality of life studies considering treatments in patients with long gap esophageal atresia, recognizing at the same time that, as Jens mentioned, long gap esophageal atresia has been differently defined. These studies are small, cross-sectional, mostly single-center studies, and heterogeneous regarding assessment methods. So you can say that there is lacking evidence that gross A or type B type of esophageal atresia are associated with worse health-related quality of life, and that there is a lacking evidence that any treatment strategy for long gap esophageal atresia is associated with better or worse health-related quality of life. Now, I want to point out a couple of knowledge gaps. There's a lack of standardization in evaluation of the outcomes, assessment methods, and norm data to use. There is a lack of prospective observational studies. There's a lack of international multi-center studies with adequate samples. There's a lack of disease-specific health-related quality of life evaluation in children and adults. There is a lack of matched controls. There is a lack of specific surgical treatment strategies being evaluated. There is a lack of statistics taking confounders into consideration, and probably you can see more. And by pointing these knowledge gaps out and with our presentation, we hope that this will work well for an interesting discussion on how to fill the gap and how you think the best approach to improve the current level of knowledge in treatment outcomes of long gap esophageal atresia would be. And I leave the word to Anke, who will moderate our discussion. Thank you.
Thank you very much, Michaela. Thank you very much, Jens, for those interesting presentations, especially the presentation of the gaps. And I open the floor to you for questions, remarks, ideas. Maybe it would be nice to have then the camera on if feasible, and you have the opportunity in Teams to raise the hand, then I can see the right order of people raising the hand. So who's the first one is always difficult, isn't it? Maybe I start with a question to Michaela. I was not aware that most of the quality of life studies have been done with a gastro symptom quality of life study. Would this explain why we like to see the difficulties with the lung issue in those patients?
Thank you, Anke. I think this is a very important question. I think our answers today rely on the way we have asked previously. So, of course, it starts with the questions that shed light on the information we know and the information we provide to the scientific community and to the patients and their families. So, yes, partly. I mean, the study by Tantan et al. Concluded that gastrointestinal symptoms could be more in long gap esophageal atresia, but at the same time, Gickley is the most commonly instrument to use. So, yes.
Okay, interesting.
Additionally, if I can say that, Gickley has never been validated for any type of EA. It probably fits, I'd say, and there used to be nothing better out there these days, but today we have a different instrument that's validated for esophageal atresia. So I personally believe this gives you a bigger picture of the disease, and also respiratory disease, as you know from your own child, Anke, is a main problem for children with long gap EA.
Not only, but as well. Lisa, happy to have your hand raised. So please, your floor. Unmute your micro.
Hello. I have one question, Michaela, regarding the family correlation with the healthcare provider, because there is a tight connection between the family and the healthcare provider for so many years. Do you know if there is a correlation between family satisfaction with the healthcare provider and the patient-reported symptoms? Do you know what I mean with the question?
Yes, thank you. I think that if you look in other pediatric populations, this has been studied more. So there are studies proving that there is such a relationship, but it has not been particularly studied in esophageal atresia. What we have seen, though, is that the level of symptom burden in the child correlates and is actually one of the predictors of the level of family functioning. And when the child turns to the healthcare provider for multidisciplinary care, it partly also relates to monitoring the symptom level and well-being and quality of life for the patient. So this needs future research to be investigated, and an important aspect, I think. I also think that the follow-up care that the patients receive should be regarded in relation to the results of the different treatment subgroups. It could be even a possible confounder, if you would like to say that.
Jens, you have comments on this?
Just in addition, Lisa, I think you raised an important point, and that was one of our potential confounders when we, in the first place, compared the Swedish and the German sample in the validation process of EA-call. And I think it's a main difference because it seems to me that the contact to the healthcare provider in Sweden is a lot closer than it is in Germany, and we discussed that in our first papers when we compared the German and Swedish samples. We couldn't prove it because we that would have been really difficult, but I believe this contributes strongly to the health-related quality of life in each and every patient, regardless of the condition.
Maybe I can add here, because I'm not only representing the story of my son, but I would say overall, I know in the last nearly 20 years, quite a few families. And if I look back, one of the burdens for families is often to be unsure, because every EA shows a different phase. And so exchanging with other families may be very helpful, but in the end, it's important to have a very trustful relationship to the treatment team. It doesn't have to be necessarily the surgeon, but in our case, it was the pulmonologist who gave us the security that we are well treated, even if it was difficult. You know, you go through all those challenges if you feel there is nothing more you can do. It's getting difficult the moment you have the feeling, I don't get the care which is possible or needed. And therefore, I'm strongly with you that this relationship and the trust between the treating team and the families may be a very big have a big influence on the outcome concerning the quality of life. Yeah. But I think it's also.
I just wanted to say thank you so much for the answers, and just saying that we thought this, but we could not prove it. That's very hard to write in an article. So that's why it's very important with the discussion here, right?
Mm-hmm.
Because maybe those things that we just can't put the hand on or put the finger on, we think this is a connection, but we cannot prove it yet. That's very important to discuss. Yep. Thank you.
Thank you. Yeah, very important point. Do we have comments on this or ideas on this, how to research it? Because I'm sure this is not so easy. But Michaela, when you said there are in other diseases already research results, maybe there might be an idea about looking for this as one of the reasons for differences. Maybe I have another question to Jens. When you said there are similar results surgically, medically between the different surgical procedures, if you look into the surgical outcome parameters, is it possible that there is no real difference because every patient needs something different, and in the end, an adapted surgical solution is the right solution, not an overall solution for every case? Question marks. Could
Hard
this
to
be a
answer.
hypothesis?
I think, but that is more opinion. I think one main factor is that the surgeon who bridges the gap knows what he does and knows his own limits and is familiar with the replacement and or elongation procedure he does. This is my personal opinion. We have to find out, and we haven't found out with the surgical outcome parameters. So maybe we will find out with the prompts. So maybe we just looked at the wrong or the inadequate outcome parameters so far. Could be. I don't know. But this is still it depends on surgeons' expertise and preference. But I hope to find an answer to that question with the prompts because nobody really asked the patient in a bigger collective.
Okay, thank you. Jan, good to see you.
Good to see you as well, Anke, and all the rest of you guys. Just as a remark for what Jens said, I'm starting to question the concept of the operation that the surgeon knows best is the operation that should be used, because I do not think that that's true, because I think that in many of I think if we would be able to run a way that you would run, for instance, oncology research, you have one set of doing things and then you assess that, and then after a while you go on and add or change or just change your protocol a little bit and see if it improves or if things go worse. As long as everybody's still going to do what they've been taught, and then I think there's going to be no progress. I think we're going to be exactly the same system for the last 20 years when I've been listening to different discussions about methods of surgical care, and I'm quite confident it's going to be similar in 20 years if we do not change approach. And also as we spoke about, Anke, just last week, that as long as there is all the centers that doing this care are so small, there's not going to be any chance by any surgeon to build an experience in actually modifying your technique or choosing the technique depending on the individual needs of the child. So that we will never come to that as long as there are so many centers doing all these children with such low numbers. So the concept of centralization and building large numbers in a few centers, it's, I think, absolutely mandatory for any of these that's going to be worthwhile. I think outcomes of any quality of life is going to be so much more depending on other factors. As you said, for instance, the relation that the team has with the parent probably will have just as big impact as any of the surgical methods given. So if we're ever going to be able to choose between these, we need to have a couple of centers that actually are able to do different methods depending on the child, or at least do enough to be able to modify the technique as time goes, as the similarity to the oncology research. Thanks.
Thank you, Jan. Jens, do you have, or anybody else want to add or comment this?
Sure, just a comment.
I thought so.
I agree with everything you said, Jan, and I didn't want to advocate for keeping all the different approaches in low numbers. So just as an addition, I think it's most important to find it out. It's what I wanted to say is just we still don't know, and that's because the research we've done so far is for different reasons, just poor quality. And I believe there is an answer to that question, but we haven't found it because we haven't examined it in the right way. So we don't disagree on that.
So Jan and then Michaela.
Yeah, and I think another aspect that a strong recollection of mine from the meeting we had in Cincinnati 2 years ago when we discussed these different methods, a large proportion of these operations are done as rescue operations. These operations, any of these ones, are done on children who've had a failed primary repair or a failed of one thing, and then they change into this. So I think also with the Great Ormond Street series, for instance, there has to be a large, I don't know, I haven't seen that paper, but my qualified guess would be that a large number of those patients actually have had some kind of intervention before. So these are probably kids that are already affected on their quality of life and also the access to the chest or whatever reason. So I think another way of not having these kids being so affected is to make sure that they do not need a rescue operation, to make sure that they have a proper operation from the beginning. I think that because you see the numbers of mortality, and you see, remember also from Boston having such large numbers of jejunal interpositions in kids who've had 4, 5, 6 thoracotomies before. I think that's probably where we should aim if we want to really decrease the morbidity in this group of people.
Michaela, thank you.
Thank you for an interesting discussion. Well, while I'm listening, we can all recognize the complexity of this topic. At the same time, I remind myself that very little has happened in quality of life research in almost 30 years. And so the goal must be to do something better, even if we can not make all solutions. So how should we do it better? So in 10 years time frame, we at least know more, and we don't repeat history. We don't do the series of 9 or 8 patients and compare them again. Here we are, a group of specialist, enthusiastic people who have a lot of multidisciplinary experience. So I believe we can do it better, and that should be the focus. Outlining, mapping out all the different confounders and how we would design. So perhaps our first step would be to have a consensus paper on a study protocol that everyone believes in, because I think that is also, if we are going to perform a study and do it better, we must believe in it, and it must be feasible too.
And we still do it. We still, I mean, the papers I've presented there, it's 13 DPA against 13 gastric polyps. We still do it. We still do that type of research, and we keep on not finding an answer to the question. It's an interesting read, no matter. It's a nicely written paper, but it just still wouldn't give you an answer to those questions. And I think we need a larger collective, which in ERNICA will be possible. And we try a different outcome measure driven by the patient or focus on the patient. I think that's the way.
Thank you. Renee, please, it's your turn. You have to unmute.
Yeah.
Good.
This is a difficult discussion, of course, where to start. But maybe I think I agree with Michaela. If we start to make a kind of proposal for research, what we want to do, and you can focus only on long gap patient for long gap then, because that's the item here this today. And then as well on the items we want to look in children, for example, 5 or 8 years, and in adults. And then this is a proposal, because it's already, I think it will take us 1 year to make such an article with a proposal where we agree about, and then we can start. And I
Yes.
think that's a good suggestion, and I would really support this also for of course for ERNICA. It would be a very good goal, and the thing is, you have to start on with a few papers. How this is what we think, and then discuss it in another webinar. How to go further with that. So I think that's a possibility to come further instead of. And then if you have a good proposal, then we have 50 centers, and at least 20 of them are doing esophageal atresia. And if they start with their to put their patients in it, it will help us. And finally, we can also maybe put some data in it in the EPSA registry on at a certain moment. But this is a start.
So being a moderator, we have 4 minutes left, and I'm a little bit excited about what I heard now in the last few minutes. I have here a proposal by Michaela and an agreement by Renee what we could do to develop an agreed study protocol. Let's go. What do we have to note now here at the end of our webinar, which will end in 3 minutes, that we can proceed from this point and meet again next year and have first results. I'm really excited about this. So what does it need? Who does it need? Does it need that we talk about it in Wroclaw? Will we talk about it? So, okay. So we invite everybody, once we have the protocol, to get in touch and discuss and give us the input. Probably we need this. From the patient side, I'm happy to announce we are by your side, because that's exactly our interest. Because when the patient thinks he has a good life quality, it's his life quality. So I think it's a good approach. And maybe we will have more information about what is the best surgical approach, or maybe we will learn that other things are much more important. So that will be the interesting part. Having the same surgery with different surroundings, with different output outcome might be an interesting result as well. Is there anything which has to be said now? Otherwise, I would even release you a minute earlier. Anybody from the people who haven't raised their hand so far? I look at the screen. Yes, here we have. Go for it. It's from Newcastle, obviously. Vinayaka, please. You are unmuted. Go for it. You have the floor. No, we can't hear you. Does anybody hear something? Maybe you write in the chat. No? Okay. So please come back to us if there is an important information. We don't want to miss it. But at the moment we can't hear you. I asked my two wonderful presentator, Michaela and Jens. Did I forget anything to mention? Or Romay in the background, who organized everything wonderfully from the ERNICA project team. Did I forget something? Or shall we say goodbye? Have a nice evening and happy Easter.
Yes, and thank you everyone for joining the webinar.
Yes.
Thank you, Renee, for providing the opportunity.
Yes, thank you very much to everybody.
Thanks, everybody.
For attending.
Thank you
Happy
very
Easter.
much.
Have
See
a
you
nice
in Wrocław.
evening. Bye
See you,
bye.
Wrocław.
see you in Wrocław.